Good evening once again, colleagues, and welcome to our first Rudasa REM monthly webinar for 2026. And thank you all for joining us this evening. So today's session is especially timed as we approach the World Malaria Day on the 25th of April, which is a global initiative aimed at raising awareness about malaria prevention, control, and elimination. We know that malaria still remains a significant public health concern, even in South Africa, particularly in provinces such as Limpopo, Mpumalanga, and northern part of KwaZulu-Natal. And I know as clinician recently, there have been some news around, but Prof will confirm to us if they are true or not, that there's an increasing concern due to the rise of malaria cases, including the reports from the Gauteng where cases and the deaths have increased in the early 2026. So this highlights the importance of early recognition, prompt management, and ongoing vigilance, even in non-endemic areas. So this makes today's topic, recognizing and managing the patients with malaria at PHC, extremely relevant and important. So some housekeeping rules before we begin this webinar, some few points. Please use the chat box to submit your questions during the session, but we'll attend those questions at the end of the session. But also you can ask your questions at the end of the session. We will unmute you if you want to speak. Regarding your CPD point, you will earn 1 CPD point. You must attend at least 45 minutes of the webinar. And at the end of the webinar, we have the poll that we have there. Please complete it. And please now ensure that you change your screen names so that we can recognize you and it can be easy when we are doing the CPD's allocation. And we know that our administrator will submit the attendance to HPCSA on your behalf, so you do not need to submit anything yourself. So please note that the CPD allocation may take 1 to 2 weeks, sometimes up to a month, right? So now I would like to introduce our speaker, who is the Professor Blumberg. I'm sure I'm pronouncing your surname right, Prof.
Yeah.
So Prof is an infectious disease physician and medical microbiologist. She's affiliated with NICD, Stellenbosch University, and the University of Pretoria. Her work focuses on outbreak prevention and response, malaria and travel-related infections, zoonotic disease, and viral hemorrhagic fevers. She has played a key role in managing outbreaks such as Mpox, cholera, typhoid, rabies, and avian influenza, and has held a senior advisory role with the World Health Organization, including chairing the Strategic Advisory Group for Infectious Hazards. She is currently the chair, the United Against Rabies Steering Group. We are truly honored to have her to share the expertise with us this evening. Without any further ado, Professor, thank you for joining us.
Thanks,
Over
Mr.
to
Lizzie,
you.
for that very generous introduction, and a great pleasure to be here. I think this talk is timed very well. And let's have the next slide. And please post questions, put up your hands, share your experience. You're out there. So this was reported this week that Gauteng is facing an alarming malaria outbreak with 414 cases and 11 deaths in 3 months. And this is more cases and deaths than the whole of last year. So that's the headline. In fact, they're all imported cases. Many people travel from Gauteng to well-known malaria areas. There's nothing unusual about the areas at risk this year, but we've had lots of floods. Many people are traveling as compared to last year, particularly to Mozambique. That had some political upsets, and it is the high season. So I think it's important to be aware that wherever you are, you will see increased cases, but I think the deaths are alarming. And I'm sure this was related, there is an audit that's being done related to missed diagnosis late diagnosis. It's the flu season. People have forgotten about malaria, and both the season and the symptoms overlap with flu. And I think that's a key message here. Don't mistake malaria for flu, and vice versa. Don't mistake influenza and miss flu. Malaria needs urgent treatment. We have excellent diagnostics, excellent treatment, but if you delay an extra 2 or 3 days, the patients are in trouble, as these were. So we can expect to see, I think, a late season going right into May, as we did in 2017. So be on the lookout for malaria. And we may have a busy flu season, but malaria is the one to diagnose urgently. Next one. So I think this is the most important slide, and you will see it again. High index of suspicion for malaria. Ask travel histories. Ask about places of residence. In any patient with fever, flu-like illness, acute progressive organ involvement. And if there is travel to malaria area or they live in a malaria area, as many of you are working in malaria areas, you must test for malaria until it's disproved, irrespective of any other considerations for any other diagnosis. You cannot exclude, you have to confirm with a laboratory test. You cannot exclude it clinically. And there are two available. The gold standard is a smear, which is obviously only available in laboratories within hospitals. But the main way of diagnosing malaria in most of your primary healthcare clinics, and including many of your EDs in hospital, is through the use of rapid diagnostic tests. And if you see that picture on the right of that little boy having his finger pricked, or not so little, that's how it should be. That's a clinic that I've worked in Mpumalanga and Bushbuck Ridge, quite close to the Kruger National Park. If you walk in there and you've got fever, or you complain that you're tired and fluey, it's the first thing you get. And then you get your blood pressure, temperature, and pulse. You will get a malaria test. And we need to be doing lots of malaria tests. And if there are lots that are negative, that's fine. We're not going to miss them. So there's an urgency to do it. You can't give medication, send them home and say, come back on Monday if you're not better, and then test. It has to be done immediately. If the blood is sent to the lab, and it may well be in a number of hospitals, you need to get the results and repeat it if it's negative. If it's positive, you need to notify the NMC app, and you need to start urgent treatment based on an assessment of the severity of illness. Now, I've added that little muzzy mobile just to remind me that occasionally mosquitoes that are infected do travel. They get into suitcases, aeroplanes, and taxis, and they travel to Gauteng, for example, very hungry when they arrive. And if they've survived the journey, they're out for their next meal, and they will bite a number of people. There's no history of travel, and those cases are often missed. So just be aware of, any unexplained fever, progressive illness, low platelets. Always think malaria, especially in South Africa and Southern Africa. Next one. So that's a key slide. Next. Mxolisi, next one, please. Not moving. Mxolisi, thank you. Okay, so when you look at patients who've died of malaria, and audits are done every year in every province, it's this. No, go back. I think we're going ahead of me. Please go back
Okay,
one.
let me see.
Yeah, something's going out, I think. Okay, they're the same problems. Delayed presentation to a health facility. The patients aren't aware of the disease. They don't know that they need to present urgently. And when we're talking delayed, it's an extra 2 or 3 days. You need to present and be treated in the first 48 hours of illness. If you wait till 4, 5 days, 6 days, patients are in trouble and will deteriorate rapidly. Misdiagnosis, nobody thinks about malaria. And I think that's much more of a problem outside of the malaria transmission areas. It's not just Gauteng, it's all our other provinces where patients end up. Delayed treatment, especially in hospital, or misassessment of the severity and incorrect treatment choices. Now, for uncomplicated, we use coartem. For complicated, we need artesunate. If you don't institute urgent treatment in hospital, and we've had delays in hospital, 48, 72 hours, while patients are waiting in the ward, it is a disaster. And there are a number of court cases related to this. If you call a patient mild and actually they're severe because you misassess them, you will give the wrong drug and they don't do too well. And then once they're in hospital, they're not the easiest cases to manage. They progress rapidly. If you leave them, for the weekend and hope you'll come back on Monday and kind of pick up where you left off, it's not going to happen. So careful fluid management. There's a very narrow window between giving fluid and overhydrating and leading to ARDS, which is really hard to treat. Missing hypoglycemia. Any patient with malaria who's fitting, depressed level of consciousness, check the glucose. That may be the problem. And then an early complication is renal failure. And most hospitals cannot manage these patients. And getting them transferred for early dialysis is really very difficult. So I think the key message is let's treat uncomplicated malaria and not end up with these problems. Next one. Okay, so what about malaria control in South Africa? Well, we actually have a very good national malaria control program, and we also have provincial control programs, mainly in the endemic provinces, in Mpumalanga, Limpopo, KwaZulu-Natal, and then we actually have some semblance of a program in Gauteng who do it very well. And since we see most of the imported cases, they do a very important job. But we are moving, because of good control, to malaria elimination, which means there will be zero local transmission. So we're not going to get rid of the mosquitoes. We will still see imported cases from across our borders, but hopefully we won't see any patients who acquire malaria locally. So how do we do this? Well, we've done for years, and we've been a leader in this. Prevention in malaria endemic areas is to spray the indoor walls of many houses, not all, but those in high-risk areas, with long-acting insecticides. Indoor feeding mosquitoes go and feed on a patient, then they rest on the wall, and then they absorb the insecticide and they die. The problem is it's very labor-intensive. You have to employ and train people every year. It's not easy to do this. We have vector resistance to the insecticides. We have community resistance. The houses are not that easy to spray, as the days of DDT, and much simpler housing. And so there are many challenges. And then we have the outdoor feeding mosquitoes, and many people get bitten, when the weather is hot and they're sitting outside, or they go to some communal gathering in the village. There's also an attempt to deal with breeding sites using larviciding, but that's not easy, especially, if you can't find them, or they're not fixed, or the floods come. That's not an easy intervention. There's border control, and that's a picture from the border with Mozambique, KZN. And as people come through for market day and to move on to wherever they're going, many will be carrying gameticides. But because they've grown up in malaria areas, they're not ill. They have good immunity. But those gameticides can be passed on to our mosquitoes, and then the cycle will continue in local populations. So as they come through, it's really an excellent system. They cannot move into a taxi or move on until they've had a malaria test. If they're positive, they treat it there and then. And it's really in a very efficient program that's well accepted. There needs to be notification of all the cases. I'll come back to that. But there's a program of active surveillance. If a patient presents and is notified at a clinic, there's a program to go to the village test all the people in that household, test people in the households around, looking for other people who are symptomatic and others that are infected, and test them and treat them early and break that chain of transmission. There's treatment mainly in the clinics and hospitals. It's free. And in addition to the treatment for the disease, there's been the introduction of low dose, stat dose of primaquine. When you are infected with a parasite and you are treated, you will get better, but the normal life cycle will continue to metasites, which are the transmission form picked up by the mosquitoes, and you will still need to get rid of those, eliminate them to break the train of transmission. So that's done only in our malaria transmission areas. It's been working very well in Mpumalanga, KZN, perhaps less well in Limpopo, where we in fact have most of our cases. Next one, please. So where are we with malaria? Msolisi, are you having some problems?
I'm here, Prof, but they say when the movie.
Okay. So early and accurate diagnosis and the institution of effective treatment is really your responsibility. And it's incredibly important in reducing morbidity and mortality. And we really should be seeing no deaths from malaria. We have excellent treatment. We do monitor parasite resistance. It's an important part of the program. And to date, we have some lumefantrine tolerance, but we have the companion drug, the artemisinin, to counteract. So at the moment, we don't have a major problem, but it is emerging in Africa. I've mentioned the gametocide treatment. It's your responsibility to report, to notify, because accurate data collection is what informs us if we are having the right interventions, how successful we are, where are the patients acquiring the disease. Every single person will get interviewed in a malaria transmission area and will kind of tell us where we're going and where our problems are. I think just important to mention that Mozambique, the malaria is called stable. You kind of see the same malaria almost every year. South Africa, we have much less. We have no one with immunity here, like they do in Mozambique with repeated infections, but we are prone to epidemics. And in 2000, we had a major one. 2017, we had another one. And I'm not quite sure what we're seeing now, but I think we need to be prepared because of the rains, the floods, and maybe some late peaks. Next one. So that's your role. Oh dear. Next.
Yes, it's up.
No, it's not. It's not.
Let me go further and then.
Just press once.
Okay.
I think it's a graph.
Can you see it now?
Can you try and... Yeah. So you mentioned World Malaria Day. That's this week. And the theme is driven to end malaria. Now we can, now we must. And I think it's a very clear message. Malaria is up and down in the world when funding goes down, when the climate is kind of, a bit erratic and there's cyclones, we see ups and downs. Next one. So this is our malaria map, 2018, and more currently, we've actually done very well. And if you see the pinkish areas, particularly in Limpopo, they've been pushed back. The yellow areas are low-risk areas, and you can see KwaZulu-Natal, which in 2000 had major outbreak, is actually now a very low-risk area. And despite being on the border of Mozambique, there's actually been pretty good control in southern Mozambique, but we need to keep it up. So very few cases come from KZN. The program's done extremely well, but anything can change, and especially with funding losses, whether we need to make sure that we're keeping on a winning wicket and those pink areas recede. And I think we need to work harder in Limpopo. Next one. So how many cases have we seen? Next.
It's up, Prof. Can you try,
No,
sorry, Prof, can you try to control it on your side? I made you a co-host. I'm not sure if that's possible.
you can try. Okay. Hosting tools. I don't know. What do you want me to press? Okay. Well, here is some statistics, and no, it's not. I don't know. Okay, I'll try. These are the statistics. Cases were down last year, less than 10,000, and they do differentiate between imported and local, but I think we're going to see some peaks this year. No, it doesn't want to go. Let's see. Next. No, can't. Doesn't want to go. Sorry. There we go.
No
All
problem,
right,
Prof.
here are some cases. Don't move. Let people have a look at these cases and think about what you would do. So the contractor working on roads in Kruger Park complained of the heat and said he still felt hot after the sun went down and he felt really weak. So think about what you would do in this person. Then there's and we'll come back to them at the end, an 8-month pregnant woman with fever, lives in Bushbuck Ridge in Mpumalanga, complained of burning on micturition and dark urine, went to the clinic. They did a sort of dipsticks and looked a bit busy with a few of the blocks, looking positive, treated for a UTI and sent home. Wasn't so well 3 days later and needed admission. High fever and some organ failure. 3-year-old child lives 20 kilometers from Manguzi Hospital in KZN, went across to southern Mozambique for Easter holidays, now fever and vomiting. What do you think? And then a 45-year-old businessman lives in the Eastern Cape, presented with fever and flu, frequent travel to Mozambique and Zimbabwe. So what are you thinking? Next one. No, I'm unable to do it. Oh, there we go. I did it. Okay, just a few basics. Malaria symptoms in adults. I'm sure many of you know this. Incubation period, anything from 10 days, usually up to about 3 to 4 weeks, but can be a bit longer. And especially for some of the rarer relapsing malarias, actually might occur after that. Typically, it starts suddenly. There are cold shivers, hot sweats, a period of feeling actually perfectly fine, and then the paroxysms start again. Headache, those rigors I've just described, feeling like the bus went over you. And most importantly, and where all the confusion occurs, an influenza-like illness. I think, doctor, I've got a flu. And that's the contractor in the Kruger National Park. We were doing a surveillance because there'd been an outbreak. We were testing for parasites in a number of the staff, and he just joined the queue. Thank goodness. Otherwise, I think he would have been in trouble by the end of that week. No, it doesn't want to go. Sorry. There we go. Children symptoms are much more subtle, much harder to diagnose, much more rapidly progressive, and you don't have the typical paroxysm, cold shivers, hot sweats, headache. Fever is kind of always there. Lethargic, don't feed well. Vomiting is very common, and rapid breathing is a concern. Don't put it down to fever. It may well be metabolic acidosis, which is always a sign of severe illness. So always do the respiratory rate. Next. Sure, this is not. Here we go. Okay, the big problem with malaria is that it mimics many other infectious diseases, and many other infectious diseases mimic malaria. But don't miss malaria. It's the rapidly progressive one, and it's treatable. Be very careful of malaria in persons who've got other diseases. They think it's same old, same old. Difficult to diagnose in the very young and the elderly. Again, people don't think malaria. And malaria in pregnancy is often missed and misdiagnosed as pregnancy-related infections. Think about that young woman who was treated for a UTI. So the commonest, if you look back on patients who had severe malaria or died of malaria, the first diagnosis was flu. COVID-19 used to be it. And it's wrong. It wasn't flu. It was malaria. And it's at this time of the year, overlapping outbreaks, symptoms, it's a major problem. Patients who present with depressed level of consciousness, they don't always give you a history. So meningitis, encephalitis, don't miss cerebral malaria. Patient who's got a fever, who's got depressed level of consciousness in a malaria area, or you get a history of travel and that might be missing, you must check for malaria. Can you get the two together? It would be unusual. But even in the best clinical hands, it's quite hard to differentiate. And yes, you may end up doing a CSF, but you have to do a malaria test. Patients who are jaundiced, and malaria is part of the differential, always have severe disease. But viral hepatitis is much more commonly diagnosed. You see a patient with jaundice who's vomiting, who's unwell and got fever. You go, oh, viral hepatitis, let's send off bloods. But you miss what is complicated malaria. And that's a common misdiagnosis. Septicemia, severe malaria look exactly alike. And then occasionally we get patients who've traveled in Africa, live in endemic areas, and I have to say, if I look back on patients sent to us as Ebola, who traveled quite widely, they all had malaria. They didn't actually have Ebola, CCHF, or other. And then there's lots of ticks in the summer, severe headache, prodromes look exactly the same, but think malaria. They kind of occur in the same areas. Next one, please. Okay, so you've seen the slide. You have a patient where you suspect malaria, and or they've gone to that wonderful table in Shlivakani Clinic, and you have made the diagnosis. So remember that key message. RDT should be in every clinic, should be in every ED in malaria endemic areas. Outside of the endemic areas, you need to think about where to place them. And if you have rapid laboratory access and results and trained people, that's fine, but you don't want delays. You really can't afford, to send blood away and get the result 24 hours later. So there's an urgency to test. If you suspect it, you do it. There's no trial of therapy of antibiotics. It's your responsibility to get results. And if the rapid test or the smear is negative, you need to repeat the test within 24 hours. One negative test does not exclude the diagnosis. So rapid tests are highly sensitive. They're very accurate, very few false positives or negatives if you do them properly. But if it's early in the disease, yes, they may be negative, and you need to repeat them. You need to use a Plasmodium falciparum only test. The combination rapid tests cause a lot of confusion in interpretation, and Plasmodium falciparum is the one that we worry about and the most important cause of severe malaria. So I think a well-done RDT is really, really critical. Get a result within 30 minutes. The smear will tell you if there are other species. It will give you a quantification of the number of parasites. I have to tell you that the quantification is quite badly done, and more than 5% is always associated with severe malaria. Lower percentages, you can still have clinically severe malaria. It's not excluding it because there's a sort of cycle to the parasites in the peripheral blood. So both need skills, and you cannot assume that somebody working in a lab actually has those skills at 3 o'clock in the morning. They need to look at a certain number of fields. They don't always do a thick smear, which concentrates the parasite. So, if there are discrepant results and you are well trained in RDTs, that's where you need to go. If they don't match up, you'll have to review the results and see where the problems are and may end up just treating. So RDTs, next one. So a couple of lessons on RDTs, and I think this is the most important part of where we are. So this is the kind of ingredients. You need to ensure that the sample collection site is clean and you have all the materials. You need the lancet, you need the RDT, the swab, you need some gloves, some buffer, sharp spin, I think you know all of this, and a marker pen. Let's have the next one. Ready to go. And you need to label the RDT with the patient's name, the clinic, the date, and the patient's number. Now, they're going to be sent to the NICD to test for resistance. That is part of the program. So we need all those details. And if you don't label them and you have lots of them, you're going to get them mixed up very quickly. So you need to select the non-dominant hand, position the hand palm side up, select the second, third, or fourth finger, apply pressure to the finger to assist with blood flow. Okay, so you choose those fingers, not the thumb. Next one. Just add the next little diagram. Clean the fingertip with alcohol swab, not a swap. Just let it dry. Then you need to massage the finger, work outwards to prevent contaminating the area, and just make it sure it's dry. Otherwise, you're going to dilute the blood that's being there. Okay, next one. Hold the finger firmly and prick the finger off the center with a clean, sterile lancet. So it's not on top of the finger, it's a little bit on the side. Next one. Now, it's quite important how you do this. Wipe away the first drop of blood and then gently press the finger again until another drop appears, and that's the drop you collect with the pipette. Next one. And you cannot believe how many mistakes are made. You've got the result window, the blood well, and the lysis well. Okay, next one. So you put the blood in the blood well, you put the lysis in the buffalo well, and you read the result on the top. There's a control line and there's a test line. Next one. And don't mix them up. That's the sort of the way it happens. The blood moves along and it will be an interaction. You are picking up antigen or enzyme, and you will get a line that shows it's positive. Okay, next one. Don't worry too much about that. Okay, next one. Keep going. Okay, keep going. All right, don't mix the holes up. And when you put the buffer on, make sure that you just put 2 drops. People use it like a ketchup bottle. They finish the buffer. If there's no buffer in the clinic, you've used too much. And then you read. If you must have a control line. If you don't have a control line, it's invalid. You read the control line and you look for a positive test line. Even if it's faint, it is positive, provided the control line is there. Next one, please. Okay, only 5 microliters of blood. There is a little marker on the pipette. Don't add more because the test is designed for a specific amount. Next one. Just keep going so that we go quickly. 2 drops of buffer, and you start counting 20 minutes. 20 minutes, 20 minutes. If you read it within 1 minute, you're going to have a false negative. If you leave it for longer than 30 minutes, you're going to have a false positive. So the biggest mistakes that are made is not ensuring that there's a control line. If there's no control line, that test is invalid and you cannot read it. If there's a control line and the test line is negative after 20 minutes, that test is negative. If the patient looks well, educate them, tell them to come back if they're not feeling well the next day. If they're ill, it may be something else. Refer them for further investigation. If both the test and control lines are visible after 20 minutes, even if it's faintly positive on the test line, and it's uncomplicated, treat. If ill, because you must assess the severity, refer, but you may need to start treatment in the PHC before you send them. There are often long delays, and we'll talk about that. Next one. Okay. So malaria rapid tests, as you know, are only valid for diagnosis. They may remain positive for weeks after successful treatment, and they cannot be used for following up patients. If somebody is treated, they come back, they're still ill, they need to be referred for a smear. They can remain positive. We are seeing some malaria strains that are not picked up by these tests, not a problem in South Africa. It's a genetic abnormality, and there are alternative tests. But at the moment, our tests are well evaluated, and they are highly suitable for what we see here. Next one. Okay, so I think I've mentioned that. The false negative is the biggest problem, delayed reading false positives. RDT versus microscopy. A good microscopist can pick up fewer parasites. An RDT is probably slightly less sensitive, but it's much more useful and get a quicker result in many of your settings. If the one is positive and the other is negative, because many of the NHS labs do both, then go with positive, particularly if the symptoms fit, and treat and have an open mind. You don't need both tests. If the RDT is positive, the patient's clinical symptoms fit, that is enough. You don't need a confirmatory microscopy to start treatment. A positive RDT done correctly is enough to equal treatment and to notify the patient. Very, very important. Next one. Okay, what about treatment? Well, it's standardized. We do resistance testing. We've had some changes over the last 25 years. There may be some in the next 5 years, but currently you have only one choice, and that is Coartem, a fixed drug combination. It's very effective. It's 3 days of treatment. Patients feel better quite quickly, and it works, provided it is administered with fatty food. Otherwise, it's not absorbed. So there are different ways. Patients are anorexic. They don't always have food available, but it becomes a problem, and you have to be quite creative in some of these patients or provide them with food. So full cream milk, a sandwich with some margarine, a bit of oil, in whatever food or the porridge, but they do require fat for optimal absorption. In terms of symptomatic relief, please use paracetamol. Do not use non-steroidals. Patients have lowish platelets very often. Some of them on borderline renal failure, and NSAIDs do not really offer a great advantage in many of these cases. In fact, quite the contrary. The first dose should be given under observation. If there's vomiting, repeat it. And if they persist with vomiting, they need to be referred. And that's often a problem with children. Pediatrics, there's no preparation. There's no lower weight limit. You need to crush it with some jam, some chocolate syrup, or whatever is available. And unfortunately, if it is vomited or the children don't take it, you will have to refer them for parenteral therapy. It's dosed according to weight. For a normal adult, 4 tablets stat, 4 tablets after 8 hours, and then 4 tablets twice a day for 3 days. We're looking at increasing the dose or the duration of therapy, so twice a day for 5 days in patients who are large, certainly over 100 kilos, maybe over 80 kilos. We occasionally see treatment failures. Remember, this drug combination was mostly tested in Southeast Asia, where people are quite small. Mostly it's fine, but every now and again you do get failure. And then to mention again that if you're in an endemic area, every patient with positive malaria must have 1 dose of Primaquine. Don't give it in pregnancy. Don't test though. We don't give it to children under the age of 8. And we've not had problems with any G6PD deficiency issues. So that's given and is provided by the program. Outside of malaria transmission areas, Primaquine is not added to treatment. This is where you've got the mosquitoes and you want to break the chain of transmission. Next one. Okay, so the next decision is you've got a positive result, you want to start treatment, you must decide, and this is the hardest part, is it uncomplicated malaria or severe malaria? So the one, the patient on the left was very easy. He walked in, he gave a great story, he wasn't jaundiced, he had a normal respiratory rate, he was uncomplicated. Patients on the right is very easy, having a convulsion, depressed level of consciousness, that's obviously complicated malaria. It's a kind of line in the middle where they really appear pretty ill, where I think it's better to put them into the category of severe malaria and give appropriate treatment. The problem with coartem is if you give it to patients who are kind of borderline or progressing to severe malaria, they're already day 4, day 5, they don't do well. And they will land up getting worse, deteriorating very rapidly. So it's one of the key things of malaria is this underestimation of severity of illness. If gut feeling tells you, worried about this patient, err on the side of caution and move them over to the right, to severe malaria. Next. So that's uncomplicated malaria, and it's really difficult to give you a tick list. So a patient who walks in, who's not persistently vomiting, absolutely no jaundice, a tinge of jaundice means you've got complicated malaria, gives you a good story, and importantly, things we don't do is measure the respiratory rate. And if it is up, we always say, it must be fever, but it may not be. It may be early metabolic acidosis, and that's a key early sign that patient will deteriorate. So do respiratory rates to guide you. Next one. Uncomplicated malaria. Ensure the patients understand the need to complete the full course. They do need some oral fluids. They need to take their treatment with something fatty, paracetamol for temperature control, and mostly they get better by 24 to 48 hours. But they need advice about what to look for, onset of sleepiness, dark urine, vomiting, needs to bring them back. Perhaps you missed that stage of progression to severe malaria, and they will need referral and additional treatment. Next one. Okay, so who to admit? Anybody with any sign of severe malaria. Now, when I've assessed the bed letters, the bed charts of patients who have not done very well, you will just see simply cerebral malaria. Now, malaria is a multi-system disease, so you need to assess every system. Is it complicated? Is it involved? Just don't just look at the level of consciousness. I've mentioned jaundice always means severe malaria. Increase in respiratory rate is invariably metabolic acidosis. Any CNS change from agitation to convulsions to coma, incoherence means severe malaria. Dark urine, not passing urine, those are things you can do easily in primary health care. And they are the reasons you examine patients and carefully. Refer pregnant women. They complicate very quickly. Refer children under 6 months. They complicate quickly and they often vomit. Anybody who's vomiting persistently. And then if they come back at 3 days because they're not better or they're worse, you need to refer them for smears and a change in treatment or supervised treatment, depending on what you feel. Okay, so those are really key things. Respiratory rate can be an ARDS. It may be a metabolic acidosis, but it's something that we need to be very careful of. Next one. So these all need to be admitted. And any patient that you're worried about just doesn't feel right, you need to refer them. Now, if they do come back at 2 or 3 days, look at what you gave them. Were they compliant? Were they vomiting? What was the dose? Are they kind of large and maybe they need more treatment? Did they take the tablets with food? Review the diagnosis. Perhaps they're Mozambican patients, they've got parasites, but actually their fever they have parasites just because it's the season, but actually they have something else wrong with them. And then anybody who comes back after you've seen them and you started coartem, progressive signs and symptoms, they need urgent referral. And when you refer patients, you need to kind of have an idea of how long it will take them to reach the nearest hospital, and it can be many hours. We are trying to have some clinics, PHC clinics, have a supply of artesunate, which can be used while the transfer is in progress, but that is happening at the moment. Drug resistance is not common, but if you have a patient who's not settling and everything else has been reviewed, we need to look for drug resistance, and that's done at the NICD. We do it routinely on the rapid tests, but we will, obviously that's done, as a program. It's not done immediately, but this is something that we can offer you. The other reason might be a mixed infection with non-falciparums, and maybe what you're seeing is, the Avalia or the Vivax kind of appearing. But mostly, it's the weight. People with larger weights, and they've not taken the drugs with food. That's our commonest cause of non-response. Next one. Okay, so if patients do need admission, they need to be admitted to the highest level of care. Not all your hospitals have ICUs, I accept that, but they need a place where they can be monitored a lot more carefully than an open ward. One of the biggest problems of managing severe malaria is obviously a delay of, any 3 days. That's going to make a difference. Your underestimation of disease severity. Patients been going for 3-4 days. They're really not looking well, but you can't kind of pinpoint any specific complication, and you give them coartem. That's a big problem. What you see is not what you get, and that's why patients need to be very carefully followed up, and they need to know what are the signs that need to bring them back. That respiratory rate, I told you, is very useful. And if you do have to admit them, you need to consider what treatment you're going to change to and what is the best supportive care. And also how you're going to transfer them and maybe pre-referral treatments. Next one. Okay, so now severe malaria is an emergency. Artesunate is the treatment of choice. There are 2 different preparations. There's still the Garson one in the private sector, but the public sector has a new artesunate preparation called COSFARM. They're kind of equivalent. It's registered, it's available in an ED in a hospital. It should be kept in the emergency department. And before you refer a patient to the ward, you should give the first dose. Otherwise, there may be long delays before the duty doctor sees them. It's kind of a busy time when you're on call for the whole hospital. The dosages are according to weight, and it's different in mostly younger children, less than 20 kilograms. You can use it in all patients with severe malaria or where you are concerned, any age, any weight, and all trimesters of pregnancy. Once you started coartem, artesunate, you are committed to 24 hours. You cannot stop it, and you shouldn't stop it before you've done 24 hours. You've made that commitment. You come the next day and they look a lot better. Just continue for 24 hours and give it until they're looking much better, they're able to take oral medication, and then switch to oral coartem. And, you can give artesunate for many days if you have to. But once you finish giving it, you must give a full course of coartem. Remember, artesunate is single drug therapy. You won't, treat every last parasite. Coartem is combination. And if you don't finish with a course of coartem, those patients will be back the next week, I assure you. So make sure they have it. You don't need a washout period. Just order it from the pharmacy. They're much better. Give them coartem with food and make sure they have a full course. Next one. Okay, I think we might have had that one already. Let's move on. So once they're in hospital, and I will do this very briefly because this is PHC management, you do need to prescribe fluids. You prescribe the drug. You describe how often they should be given, but always there's just this fluids. I don't know what that means. Malaria patients need to be run dry if they are receiving intravenous fluids. Adult, never more than 2 liters in a day. Monitor the UNE, the urine output, and if the urea creatinine is going up and the urine is going down, they need early dialysis. They don't need fluid boluses and endless trials of furosemide. They need early dialysis. It makes a big difference. And renal failure is an early complication of malaria. It's often what kills patients in district hospitals who don't have access to dialysis and no option of referral. Antibiotics, it's a kind of mute subject, I think for children, because they often have a secondary infection. Don't forget the glucose monitorings. We got quite used to steroids, especially for ARDS. For COVID, it has no role in malaria. Occasionally, you need to give blood. And remember, if a patient develops a respiratory distress in hospital, and that often happens with severe malaria, they are getting an ARDS. And if you get called to them and they're agitated, confused, they need to be diuresed, they don't need sedation, they need oxygen, and they need to be managed for ARDS. Big mistake that's made. They change quickly. I think there's just 1 or 2 more slides. Next one. Okay, let's go back to our cases. So anybody want to offer something for the first one? So that was the contractor working on the roads in Kruger Park. He knew nothing about malaria. He just came from Pretoria to do the job, and he got a fever. Because there was the surveillance in the camp, he just joined the queue. Otherwise, I think he would have waited for his day off 5 days later, and then went to a clinic where he was staying, and he might have been much sicker. So we tested him. He was positive. He had no signs of complications. We started him on Coartem there and then. We gave him a little phone call twice a day to kind of encourage him, and he did very well. The next patient is the common problem that happens with pregnant women. So she lives in a malaria transmission area. The burning on micturition, well, that's not uncommon in pregnancy. The dark urine, perhaps that's hemoglobinuria with the malaria. You must test them for malaria. So anybody living in a malaria area who presents with a fever needs to be tested. And the big problem is pregnant women, because you think it's a pregnancy-related infection. The commonest one is UTI. They get treated for UTIs, malaria is missed, and the disastrous outcomes happen. This child went across to Mozambique. Northern KZN is quite a low risk, and it's high risk season over Easter, contracted malaria, and returned home. Fever and vomiting is very common presenting features of malaria, and needed diagnosis and treatment. There was a delay and unfortunately needed treatment for severe malaria. But this is not commonly seen in our malaria transmission areas where I think the awareness is much higher. And then the businessman presented in the Eastern Cape where they don't often see malaria, but he told them, I go to Mozambique very often. I sometimes go to Zimbabwe, and fortunately he pushed patient power for a malaria test and he got treated. Next one. So just a couple of cases. I think we're almost done. So malaria in pregnancy is terrible. The risk is most in the 2nd and 3rd trimester and 2 weeks postpartum. I've spoken about the misdiagnosis. Abortion happens, prem labor happens, SGAs happen, but the biggest problem is for the mother. So ARDS, hypoglycemia, anemia are major complications. So be careful about assessing these patients. I think they should be admitted. If it's uncomplicated and it's truly uncomplicated, Coartem should be given. It's safe. If it's more severe, any of these complications are there, or you're really concerned about the patient, do not hesitate to go immediately to artesunate. Any trimester of pregnancy, you need the best treatment. Avoid the Primaquine and give it, we don't need it. Not good in pregnancy because we don't know the status of the fetus. Next one. But pregnancy and malaria, rapidly progressive. So key messages: think malaria, test if any fever, flu, illness, travel residents in a risk area, be careful of pregnant women with fever. Remember, malaria is acute, progressive, and just remember, even if you're working outside of a malaria area, the mosquitoes occasionally travel, and we don't want to miss these. Be aware of the warning signs, the signs of severe malaria, the jaundice, change in mental state, increase in respiratory rate, reach for the artesunate, make sure it's in all your EDs, and then follow up with coatum. Remember the food, and remember how you must do rapid tests, because that's where it all starts. And don't have problems of false negatives, which is really a recurring problem. So I think I'm going to stop there, Lizzie, and people can ask any questions.
Thank you. Thank you so much for that insightful presentation, Prof. I really enjoyed. You are such a clear and engaging teacher. And it's really special for me personally, so, having been your student back in
Oh, really?
2024 during
Oh,
the
my
diploma
gosh.
in tropical medicine and,
Oh,
and hygiene.
wonderful. Oh, that's great.
Thank,
Yeah.
thank you so much. Thank you so much, Prof. Now I think we will move into a Q&A session. Since I was sharing the slides on this side, I couldn't access very well the chat box to note the questions. But if colleagues, they can feel free to post the questions in the chat box and then we'll go through them, or if they prefer, they can ask the question verbally. Then we'll unmute so that we can take the questions.
Yeah.
So you can, colleagues, raise your hands if you have questions.
So
Then,
Indira
okay.
Govinder's raised hand.
I've
Indira?
Hi, thanks very
unmuted.
much. Can you hear me?
Yes, loud and clear.
Thanks very much for the presentation, Prof. I just have a question about notifying someone who, like notifying, a person who tests positive for malaria. I've had some patients who were from Mozambique who were undocumented and had positive rapid tests, and we were just wondering how important it is to have like an ID number or something on that, does it matter essentially? So what do you need from that notification? Thank
I
you.
think as much information as possible. So the malaria program will also collect some documentation from the clinic, as well as the NMC forms. So it's a sort of dual system, but it's important, and I understand some of the difficulties. First of all, it's to identify the cases, and in a rural area, a malaria transmission area, every patient will be followed up within 48 hours, and there will be a visit to the community if they are still there, and we know some of the issues. So I think it's as much information as you can get. I think undocumented travelers are not uncommon, and people don't always want to share their details, and often they don't even tell you where they've been. But I think it's as much detail as you can access. That's all you can do. Jenny, maybe you've got an answer to that.
No problem.
So the notifications are used to order drugs, to order rapid tests, to kind of get us a sense of trends in the area. But individual information is important because we need to know whether the malaria was acquired locally or it is more likely imported. in our elimination program, we're not going to get rid of imported malaria. People will still travel, but it's the local transmission that will inform us if we are successful in eliminating malaria. Jenny, do you want to add to that?
No, Prof. I have another question, but it
Yeah.
sort of links to that. Thanks very much for the talk. I was a very junior rural doctor working in Northern KwaZulu-Natal in the 2000s, and it really
Oh
was
my goodness, terrible.
And I think just what you said, you can never, malaria can always surprise you. So, especially amongst women. So to have index of suspicion. My question really revolves around the role of contact tracing. Is there a role if someone has tested PHC for malaria? Is there a role to do contact tracing? We try to do it with COVID. Evidence showed that she wasn't very good. We're not very good at doing it with TB.
Yes. So absolutely there is a role, and that is active surveillance. So the patient coming to the clinic and getting a positive test is passive surveillance, and that's the notification. So the malaria program has environmental health practitioners and community workers or community malaria people who will go to the household, will test everybody within that household and a certain number of houses in the surrounding area. And that is to pick up other cases who might be very early and to facilitate treatment. In KZN, they actually test and treat on site, but also to look for people who might be carrying parasites and then can feed the local mosquitoes. So it's part of the elimination process. And the instructions are to do this follow up within 48 hours. So it's not because they're catching it from the people, who are infected, but it's the same. It's the mosquitoes that will either pick it up from positive people in the village or the in that area, and then kind of continue with the cycle. So very important to do it. That's why we need the details, and that's a major part of the program. They'll also interview the patient, and they've got this long questionnaire, which really is aimed to try and identify whether they've acquired it locally or they traveled within the previous month, and then it's more likely acquired, in a high-risk area like Mozambique. And that will tell us whether we're succeeding in malaria elimination or not. So it's absolutely critical. And the malaria program actually does very well. They're very active, KZN, very active in Mpumalanga. Yeah, I think there's some gaps in Limpopo. They're very, very important.
Thanks, Prof.
We're trying to break the chains of transmission. Since we can't get rid of every last mosquito ever. Just don't want parasites that they feed on.
Just a follow-up question, Prof, on that.
Yeah.
What will be our ideal malaria elimination definition and by when? Like what's
the date changes all the time. All these targets change for every program. I won't even tell you the first one that was set. So it's no local cases. So you have malaria in the country, but they didn't acquire it locally. So it's imported, and they acquired it somewhere else. But there's no ongoing local transmission. That's the definition of elimination. And, there've been a number of countries, mostly North Africa, Sri Lanka has eliminated malaria. So we do have the tools. It's not that easy. Primaquine, I think, is important. The active surveillance is important. The border screening is important. And that's all the other things that we do as part of control. That's what we're aiming for. I think it's 2030. Will it happen? I'm sure the date will be moved. But there are areas in northern KZN that have eliminated local transmission. So there's subnational classification now of elimination. And KZN has done extremely well.
Thank you so much, Prof. We really appreciate hosting you tonight. I can't see any more questions, so I will just pull out the poll. Please, colleagues, fill in the poll. It's important for your CPDs, and probably I'll give Prof just a minute if there's any more burning questions. But otherwise, this was a great presentation. Let's show Prof some love. Yes.
So, people can email us, they can contact the NICD. We have a 24-hour hotline. I'll see if I can put the number into the chat. And you're always welcome to phone. I see Vuyiswa is here. She runs the hotline. Help is at hand.
So just a minute, while we are still filling this poll, Prof, while I'm keeping you for a minute, with the cases they are reporting in Johannesburg, is it
No, so they're imported cases. These are
it's
travelers.
imported cases?
They're
Okay.
travelers. The headlines in that newspaper article, which was kind of, copied to every other news media, was misleading. So they're imported cases. Lots of Gautengers travel to malaria areas, especially over Easter and the holidays. And yeah, they were missed. Gauteng is, I think malaria awareness is quite low, and we've got flu, and there've been lots of flu messages, and so they just get missed. There I see the hotline. Thanks very much. Vuyiswa, thank you. Vuyiswa runs the hotline. Yeah, they were missed.
Okay.
So if you're traveling now over this long weekend, just know the mosquitoes are going to be very busy. Take your tabard, take your chemoprophylaxis, put on the air conditioning, close the screens, put on the fan. And prophylaxis is available at primary healthcare clinics for adults, and it's doxycycline, and it's available free for those who are going across the border. If you're in a malaria area in South Africa and you go to Mozambique, your risks are much higher, and maybe you might want to take chemoprophylaxis. It's free in primary healthcare clinics. If you're a child or pregnant woman or under 8, sorry, can't use doxy.
No, thank you so much, Prof.
Thanks very much, Msilizi. Sorry for the slide kind of issue, and sorry I was a bit delayed in joining. Found myself on a website, on a Zoom where there was no one else. Thanks very much.
No problem, Prof. Hope to host you soon. Thank you so much.
Thanks a lot. Okay. Good night,
you.
everybody. Be safe. Mind the